Well, tonight, Kyle Varner is going to talk about what the real problem is with the American healthcare system and how to fix it. He's going to talk for about half an hour, and then he's all yours. For half an hour or more, you get to ask him any and all questions you might have, and how his information really applies here to Maui. So, without further ado, please welcome our guest speaker. He's from Spokane. He has worked here at Tripler Hospital, so he knows the Hawaii market. And he is an internist. Kyle Varner. Come, aloha.
Aloha. Well, thank you for that introduction, Kali'i. And it looks like our PowerPoint is not working. So maybe we can take a look at that. But to start off with, can anyone tell me what the most common cause of kidney failure in the United States is? Well, it's actually diabetes, and a lot of other causes rank up there. But I think that's an interesting trivia piece because diabetes is something that can be managed really well, and complications like kidney failure can be prevented. But here in the United States, we do a really bad job of managing diabetes, and it leads to kidney failure a lot. So when I talk about healthcare and the healthcare problems and the healthcare system in the United States, I come at it from a free market perspective. I'm a guy who believes in freedom. And that leads a lot of people to calling me cruel or heartless or selfish. I don't think I'm any of those things. I think right now people are suffering, and they're suffering financially because the system is ridiculously expensive. They're suffering physically because even though they may have a health insurance card, they can't access primary care. A couple of months ago, I was working overnight in my home hospital, and I had a patient I needed to admit to the intensive care unit. We didn't have any beds, so I called around. And what I found was that there were no ICU beds in the entire city. Every ICU bed was full. And so I had to make the decision, do I keep this person in the in the emergency room and try to manage their critical illness there? Or do I put them on an airplane and send them to another city? Those were my two options. And that made me really angry. And luckily that patient did fine. But people are suffering in a lot of ways because we have a broken system. And today in Washington, they had a very momentous vote, one of many that they're going to have in the current debate about health care. And it may surprise you guys to know I wasn't interested at all in what they do. Here's the analogy I use to describe health care in America. It's a train headed for a cliff at 190 miles an hour. Now, prior to the Affordable Care Act, I would say it was a train headed for a cliff at 180 miles an hour. Things have gotten a little bit worse. I think that President Trump and the Republicans in Congress are making proposals that might slow the train down to 185 miles an hour. The fact remains the train is headed for the cliff. We have a fiscally insolvent system, people are suffering, and it's not serving our needs. I'm not interested in what Congress does this week or next week, with one notable exception that I'll mention in a little bit. We need to take stock of the problem and understand it from an economic standpoint, and once we do that, we can craft wise solutions that lead to more affordable care and better access. So what does everyone want in a healthcare system? I think that's an important place to start. And I would argue that we want, first of all, affordability. We want everyone to be able to pay their bills and not go broke. We want abundance, meaning that when you need an ICU bed, one is available. We want quality. We want our doctors to do a good job. We want the system to do the right thing for us. We also want innovation. We want things to keep getting better. Every year we want doctors to learn new ways to treat disease and get better at it. And finally, I think we want autonomy. We want a system that respects our own values. We want to be able to make our own choices. We don't want someone telling us you will or you won't have this therapy or that therapy. So if we keep those 5 things in mind going forward, we can start to see how we can craft a system that serves our needs. So there is one number that I'd like you guys to remember for today, and it's 9,086. And that was the most recent year we have data for, 2015. the United States spent $9,086 per person on healthcare expenses. That's more than double what the United Kingdom spends of roughly $4,000 a year. In fact, we're the #1 spender on healthcare worldwide. We dwarf every country. In Mexico, people live about 3 or 4 years shorter lifespans than they do in the United States, but they're only spending somewhere between $600 and $800 per person a year. So we have tremendous inefficiencies in our healthcare system. And by the way, we're not #1 in life expectancy either. So we're spending more and getting less. It's a major problem. And even if you're relatively wealthy, you can be bankrupted by medical fees. So there's a real problem, and people are suffering. And when people are suffering and they can't afford their insurance premiums and they can't afford their hospital bills, they start looking for solutions. That's why we have such a very spirited, passionate debate going on nationwide and in the halls of Congress right now. But there's some areas of healthcare where the prices are going down and not up. And that should amaze us, and it should make us look in those directions. And those areas of healthcare are cosmetic surgery and laser eye surgery. So since 1992, the prices of cosmetic surgery services have increased about 32%. Inflation, however, has added up to about 64% at that time. So if you consider inflation, cosmetic surgery has gotten cheaper. Laser eye surgery cost about $2,200 an eye when it was first introduced back in 1999. Today you can go on Groupon and get it for $890 an eye. It's cheaper, and it's better quality too. I just had laser eye surgery about 6 months ago. It changed my life. It's great. So we have to ask ourselves why laser eye surgery and cosmetic surgery are getting cheaper on the one hand, and heart surgery and the treatment of pneumonia and the treatment of diabetes is getting more expensive. Can we apply some things from the markets for cosmetic surgery and laser eye surgery to all the other healthcare and experience the same improvements in quality and decreases in cost? And I submit to you tonight that we can. The difference between laser eye surgery and cosmetic surgery and everything else is cash. People walk into a cosmetic surgeon's office and they pay cash, and they ask the very, very crucial question: how much is this, and is it worth it? And if they decide it's not worth it, they don't get it done. Or they go look for someone else to do it. Today, people travel all over the world looking for medical procedures at a lower price. And so doctors at hospitals, when faced with these cash patients who are price conscious, who want the best value for their money, begin striving to please their customers. Very much like Samsung and Apple are striving to please their customers, very much like any other company. And so we have a well-functioning market, and we have a lot of really good things happening. I compare healthcare today to Soviet breadlines. While we do have different doctors and different companies providing the services, we also have CMS, Medicare, who sets the individual prices for everything. All the other insurance companies go along. And the key point is that the vast majority of people don't participate financially in their healthcare decisions. And what I mean by this is, and the number is 11 cents. 11 cents of every healthcare dollar spent comes from the patient's pocket. The other 89 cents doesn't come in the patient's pocket. It comes from a third-party payer. That can be Medicare, it can be Medicaid, it can be Blue Cross Blue Shield, here in Hawaii, HMSA. So when the patient doesn't participate, they don't ask the question, hey doc, do I really need this MRI? They just say, okay, you say I should get an MRI, I'll get it. It doesn't cost me anything. And as the doctor, the MRI doesn't cost me anything either. We'll talk in a moment about unnecessary tests. But the point here is that we don't have anyone price shopping. In fact, I went about 6 months ago for a DEXA scan for body fat percentage. I decided I was going to lose some weight. I wanted the gold standard to determine how much body fat I have. And so I called up a radiology center. I went, they told me, okay, $80 and you can have the scan. Perfect. I went there with $80. I had four $20 bills in my pocket. I said, I'm here for my scan. And the secretary said, may I please have your insurance card? I said, no, that's not necessary. I'm paying cash. And she kind of paused. Oh, I don't know what to do. It took her 30 minutes to figure out what to do with my four $20 bills. No one pays cash, and nobody cares about the cost. Now, some people object to my suggestion that patients should participate in the economic decisions of healthcare by saying that heart surgery is different than cosmetic surgery, or is different somehow than laser eye surgery, because you need heart surgery, but you don't need cosmetic surgery, you don't need laser eye surgery. They have a point. You can have things that are medically necessary, but I would argue that the vast majority of healthcare is a spectrum of necessity. So on the one side of the spectrum, yeah, there are sometimes surgeries or procedures that you absolutely need to survive or you will die very soon. And there are also surgeries that are just not necessary or may even be harmful. But in the middle, where the vast majority of the care occurs, there are alternatives. Some are more expensive, some are less expensive. So you could, for example, come into the hospital, if you have cellulitis, an infection of the skin on your leg, and you're not septic, the ER doc might say, why don't you come into the hospital for a couple days of IV antibiotics? Well, at $4,000 a day, you're looking at $8,000 just to get started. You might say, well, I have a little bit of a better chance of getting this under control right now if I do. Or you could say, hey, wait a minute, what if I just go home, take some pills, and go see my doctor tomorrow, see if I'm getting any better? Could we try that? And the reality is that's probably pretty reasonable in the situation I just described. But it's probably not ideal. You're probably not going to have the best chance of having a good outcome. And so the ER doc's going to say your best chance is to come into the hospital. Nobody really cares about the cost. You come into the hospital. We end up not having enough hospital beds. So that's where this all starts. The economic principle that this describes is called moral hazard. You can't insure a car for more than the value of the car, because then you would increase your incentive to wreck the car. In healthcare, we don't have, as doctors and patients and consumers, any incentive to control our spending. So I order unnecessary tests every night, maybe $10,000 a night of unnecessary tests. It's crazy. I hospitalize people in questionable ways. And when I say questionable ways, I don't mean that I violate the guidelines. The guidelines say I should put this person in the hospital. I just know that, hey, if that was me and I were spending my own money, I'd probably try to go home or try to figure out some other way to deal with it. But the incentives are such that that doesn't matter. And me, as the doctor, I have to worry about malpractice, about liability. So I'm going to suggest the optimal thing without regard to cost. And that's been going on and on in healthcare, and it's bankrupting us. Healthcare is also subject to cronyism. We have businesses in healthcare, from insurance companies to pharmaceutical companies, and I'll admit it, my own profession, doctors and hospitals, who are all seeking a privileged position in the market. What I mean by a privileged position in the market is that they're seeking a way to keep their competitors legally from doing business with them, or with their customers, so that they can enjoy a financial benefit from having a monopoly. So I want to break it down for you sector by sector and show you what they're doing. So first, let's talk about pharmaceuticals. If you take Crestor or any other statin, you might be paying somewhere around $700 to $1,000 a year in the United States. If you bought that pill from India, from Mexico, from Canada, you'll probably pay less than $100 a year. It goes on and on, drug after drug. These companies manufacture them, these American companies usually manufacture them and sell them abroad. And then they go to Congress and they argue it would be unsafe for Americans to re-import these products. You guys are the ones who manufactured it. How can it be unsafe for us to buy it? We should also keep in mind that a lot of generic drugs are available overseas and again manufactured by foreign companies, but the US pharmaceutical companies say no, we can't allow Americans to make their own decisions Congress, please prevent the large-scale importation of these drugs. And what happens? Pharmaceutical companies rake in the profits by the billions. And doctors, patients, hospital systems pay the price. And it's bankrupting us. So now I'm going to call out my own profession. Doctors are engaging in cronyism. We're engaging in cronyism because we have created a Byzantine system of medical licensure that prevents people from becoming doctors. There are way more people out there who want to be doctors than who can be doctors. There are a bunch of people, I know a lot of them, who went to medical school, graduated and did well. They passed all their licensing exams, but they were unable to obtain a residency. They work outside of healthcare. You have to take classes like organic chemistry, physics, and calculus and English just to get a chance to go to medical school. So these hurdles have been placed, in my estimation, for one reason and one reason only. They've been placed so that they can raise the salaries of doctors already in the profession. Now, once you're a doctor, you also have this same dynamic playing out with specialties and training for procedures. So the gastroenterologists say, no, we're the ones who do colonoscopies and EGDs or scopes. And the cardiologists say, we're the ones who interpret echocardiograms and stress tests. Now, I'll tell you, I could learn these things in fairly short order and do them myself, but I can't get the training. I'm an internist, so I could do these with very little extra training, saving my patients time and money. In fact, I could see a world where if someone comes in with an upper GI bleed, I go down to the emergency department and do a scope right then and there. Can't obtain the training without going through a prolonged fellowship that would require significant investment of time and energy just to even have the chance to apply for it. So at every step of the way, doctors are acting to increase their salaries. And they always do it this way, and you'll find this with every type of cronyism in healthcare. They speak in terms of quality, and then they think in terms of their own paychecks. It really disgusts me because they are robbing patients and robbing the system. And hospitals are not innocent of this. In fact, they may be the biggest offenders. Would you raise your hand if you've heard of certificate of need laws? Yeah. Here in Hawaii, we have certificate of need laws. In fact, I know here in Maui, that's been a big issue with getting a second hospital up and running on the island. And what a certificate of need law says is that you may not open a healthcare facility if it will compete with another healthcare facility. Isn't that what we want? I want Apple competing with Samsung, giving me the best smartphone. I want cosmetic surgeon A competing with cosmetic surgeon B, giving me the best option. And you know what? I want hospital A competing with hospital B, trying to both convince me that they're the best. But we don't have that in healthcare. We have little monopoly fiefdoms for every hospital in this area or that area. And one hospital will have one service and they'll snipe at another hospital. There's a doctor in Iowa named Lieberchowski who has an ambulatory surgery center. He's an ophthalmologist. He has an ambulatory eye surgery center connected to his office. And he's had it since, I believe, 1999. And he has been unable to obtain a certificate of need. In fact, the local hospitals have gone to the state and said, please don't let him open his ambulatory surgery center. And so all of these ORs sit vacant. There are stories about women going into hospitals in premature labor, giving birth to a baby that needs neonatal ICU care, that care not being available there and the baby dying. And then we find out that hospital applied for a certificate of need to open a neonatal ICU, but it was denied because the hospital in the next town over-objected. This is disgusting, but it's also driving up the price of care. So hospitals are very much not innocent. So we've got insurance companies as well, and they are also huge offenders. I'm one of the people who says the Affordable Care Act was a big handout to insurance companies, and their profits have roughly doubled since the passage of the Affordable Care Act. The government said, hey, everyone, you're mandated to buy their product. If you can't afford it, we'll give you subsidies. And then insurance companies were able to raise rates through the roof, and I think probably anybody here who's bought a plan on the exchange or knows someone who has understands what that's like when you get something in the mail saying, oh, you were paying $300 a month, now it's $500, congratulations. It's harming people, and that's cronyism in healthcare. There's a particular case I'd like to address about cronyism. Anybody heard of Martin Shkreli?
Yeah.
Martin Shkreli is a gentleman, if you can use the word, who purchased, through his pharmaceutical company, Turing Pharmaceuticals, a drug called Daraprim. Daraprim is a generic drug. It means there's no patent on it. It means that anybody can buy the drug, or anybody can manufacture the drug, theoretically. It was selling for about $13 a pill, $13.50 a pill. And it's an HIV medication. It's actually an anti-parasitic medication that is used in AIDS patients with certain opportunistic infections. So it doesn't have a big market. It's a pretty small market. About 12,000 people a year in the United States get the drug. So Shkreli bought the rights to the drug, and he raised the price immediately from $13.50 a pill to $750 a pill. And there was an outcry. He got called before Congress to testify, and people were saying, how could you do this? You're price gouging. And he said, well, it's our drug. When I looked at that, I said, what in the world is going on? It's a generic drug. Anybody can make it. How can he get away with this? Shouldn't the free market immediately slap him down? Well, it turns out it doesn't quite work that way, because here in the US, you have to file a new drug application, even for a new generic drug, pay about $20 million in fees in order to conduct the studies, and you also have to obtain the drug that's already on the market in order to conduct your trials. Shkreli was smart. He set up a private distribution network so that he could prevent potential generic competitors from ever gaining access to the drug. So this is the quintessential example of cronyism, victimizing consumers. And in every instance that I've mentioned about cronyism, what we've seen is that the government partners or in some way protects a private business and then allows them to reap profits far in excess of the value they create for their customers. And that is one of the central problems in healthcare. By the way, Daraprim is available in India for 5 cents a pill.
What is the name of it?
Daraprim, D-A-R-A-P-R-I-M.
So just go on vacation and you can...
Yeah, well, and you can actually import for yourself 3 months of a drug from abroad, as long as you have a valid prescription for it from the United States. So for some people, that's an option. A lot of people, especially if they live in borders towns, whether it's for Canada or Mexico, will go down and go across the border and buy it every 3 months. But if you live, in the heartland, or if you live here in Hawaii, it's harder to get abroad to buy those. The hospitals can't go and buy the drugs and then give them to the patients. The pharmacies can't source the drugs abroad. And so that little 3-month exemption is really only carving away at the edges of the massive windfall profits that the drug companies are receiving. Now, when I get to this point and I talk about how we're just getting robbed left and right by companies partnering with the government, someone always tells me, wow, see, that's why we need single-payer healthcare. We need to get the companies out of it. And my response is twofold. First of all, I would quote Margaret Thatcher. The problem with socialism is that you eventually run out of other people's money. And the second thing I would say is, do you really want bureaucrats making your healthcare decisions? And so let's address running out of other people's money. What happens in a system where the government pays for and controls all of your health care when there's a crisis? Well, Greece experienced that. Greece may not be as wealthy as us, but I think most people would agree that at one time they were a well-developed, a well-off country. They have a government system of health care. And austerity happened. And the German creditors turned the screws on them, spending went down, taxes went up. And all of a sudden, hospitals got overcrowded, drug shortages happened, and an interesting thing happened. Doctors in Greece who had had their pay cut as part of austerity started suggesting to their patients that they give them envelopes full of cash in exchange for good care. They actually have a word for it. I don't remember the word, but there's a word for it, and it's actually become common practice. So even though the government's providing free care in Greece, you still have to pay the doctor if you want good care. Healthcare will become a political football if we let the government take over any more of it in the United States. Every time the debt ceiling comes up in Congress, they'll threaten our healthcare. Every time one party wants to raise taxes or another party wants to cut taxes, they're going to start threatening our health care. So I would ask you, do you want to give the politicians that kind of leverage over your life? I don't want that to happen, and I hope that other people don't. But finally, in any system, whether it's a capitalistic or a free market system or whether it's a socialized system, you have to have someone saying no to something. You cannot have spending without somebody bearing the consequences. You can't just have an unlimited blank check for everyone. And in a free market, people make decisions. Is it worth it or is it not? And the market reaches an equilibrium. Everywhere where the government has an even larger role in healthcare has some kind of a bureau that makes determinations about who will and who won't get care. Sarah Palin said somewhat histrionically that these were death panels. In England, they talk about quality-adjusted life years, and some guys with calculators figure out if you're this age and you have this disease, you will, with this treatment, get this many quality-adjusted life years, it's worth this much, yes or no. Bureaucrats decide. I don't want bureaucrats to decide. I want patients and doctors to decide, and that means you have to have a measure of freedom in your system. And so I advocate kicking third parties out of the doctor-patient relationship. That sounds pretty radical. And what that means is that I think doctors and patients should have a direct financial relationship. Direct primary care is something that's taking root all over the country. To my knowledge, it hasn't taken root in Maui yet. Please, if I'm wrong, somebody please correct me, but I think it soon will. It has.
There's a few docs.
There's a few docs. So it's great. You can have a retainer with your doctor. Sometimes it's $60, $70 a month. There's a doctor out in Iowa named Chris Larson who charges $60 a month per adult and $25 per child. And that covers all your primary care. You can get an appointment when you need it. And any and all healthcare decisions are between you and your doctor alone. There's no third party involved. There's a surgery center in Oklahoma that said we're not going to work with insurance of any kind anymore. It's between you and us. They charge less than half of what the other local hospitals charge for any and all outpatient procedures. People are finding that something their insurance didn't cover and was unaffordable at their local hospital is now affordable at the surgery center of Oklahoma. And the best part is that insured patients can go there, get their procedure, and then submit the bill to their insurance companies, meaning that there's actually a savings for the healthcare system. So I think that's really, really exciting. Something else that is really, really exciting to me are called health-sharing ministries. So when the Affordable Care Act was passed, there was an exemption carved out for 4 existing ministries. They were religious, faith-based groups where they said, we're going to pool together and share our medical expenses. It's insurance by a different name. We're going to share our medical expenses as a group. And one of these, they call themselves Liberty Health Share, after the Affordable Care Act said, we're going to try to open this up to as many people as possible. We don't want them to be stuck on the exchanges. And so Liberty Health Share has gone national. They've worked to expand their network, and they will offer sharing of up to $1 million of medical expenses for $149 a month if you're under 30. If you're over 65, it's $224 a month. Compare that to what you're paying Kaiser or what you're paying to the exchanges. It's pretty amazing. And to be fair, they don't accept or they don't cover pre-existing conditions. They don't let you can't be health sharing if you smoke. If you have diabetes, you have to keep it under control or you're going to get kicked out. But if you are somebody, the vast majority of people, you're going to be able to find significant savings with Liberty Health Share, and you're still going to be covered if something catastrophic happens. So that's pretty exciting. Now, I mentioned direct primary care a moment ago, and I want to just come back to that because I get asked all the time here, why did you leave Hawaii? It's such a great place, and I admit it is a great place. I love Hawaii. I wanted to stay. And so about 18 months ago, I sat down and started looking at job offers coming in, job offers from Straub and Kaiser over in Oahu, and then looking at what I could do on the mainland. And I realized first that, I can make more money on the mainland. And second, I realized that in Washington, they don't have an estate income tax. And then I realized that my housing costs would be a lot less. But with all of that, I was still not sure I was going to leave Hawaii. I love it here. But then a bill was proposed in the Hawaii State Legislature by Speaker Suki. I understand he's no longer the speaker. And it would require physicians practicing in Hawaii to accept Medicare and Medicaid patients. And the way they would do that is by not renewing your license if you didn't show them evidence that you did that. Now, I'm a hospitalist. I have to accept Medicare and Medicaid because I'm in a hospital. I work for hospitals. But my plan has always been, let me work at this high-intensity pace for the next 10 years or so, and then when I'm ready to settle down, I'm going to open up a direct primary care practice. And at that point, I wasn't sure if I'd be able to do that. I'm not opening a clinic where insurance companies and bureaucrats get between me and my patients. It's not how I want to practice medicine. It's not the way medicine should be practiced. And if I'm going to spend my life doing something, I'm going to do it well. I saw clinic in residency, and I treasured the relationships that I built with my patients. And I was always very hostile to bureaucrats and third parties getting involved. The patients make the decisions with my help. They don't have bureaucrats dictating to them. And so I said, there was no outcry over this bill. Yeah, it died quietly. But if one of the most powerful politicians in the state feels bold enough to propose this Orwellian proposal, at that point I said, no, I have to back away. I have to find a more politically favorable environment. And I regret that because I love Hawaii. And I wish that I had felt comfortable to stay here. Finally, before we open it up for questions, I want to talk about political solutions. So I told you in the beginning of this talk that I don't really care what Congress does in the upcoming months. But there's one thing they could do that I would care about, and the president actually proposed it. If you'll recall, in a Republican primary debate, Donald Trump had a real run-in with Marco Rubio. It was pretty epic to watch. And Donald Trump kept saying, we're going to remove the lines around the states. And he did this with his hands. We're going to get rid of the lines around the states. He didn't know what he was talking about. But the advisors who put that in his mind and told him to say that knew what they were talking about. And what they meant was, we need to allow people to buy insurance across state lines. That means that if Rhode Island passes favorable laws that allow creative insurance products that people in Hawaii want, people in Hawaii should be able to buy them. This should be a no-brainer. Congress should pass this as a standalone bill. The Affordable Care Act could stay in place, and they could pass this, things would get better. Because the states are actually 50 laboratories of innovation then. And one state can figure out a really good idea, and then the other states can go along with it. And I'd like to, end here by talking about one other reform idea that I heard from Senator Rand Paul before he was a senator. And I haven't heard it from him since he got elected, but he suggested that once we eliminate the lines around the states, one state should allow insurance to pay a lump sum of cash based on the diagnosis. So this would look something like, you have squamous cell carcinoma of the lung, stage 2B. That corresponds to $100,000. Here's your check. And that would be the extent of the insurance company's involvement. The patient then can take that money and get medical care if they want. They can shop for medical care, better value, and pocket the difference. Or they could forgo the care and just take a cruise around the world. But what this would do is give us a large pool of patients who are now making financial decisions regarding their health care. It would force hospitals and doctors to justify to their patients why exactly the care they're offering is worth what they're charging. And I think that would cause a huge sea change. And that's what we have to get back to, is patients making financial decisions, determining if the cost and the benefit are worth it, and weighing those. And the market works when you have hundreds and thousands of people individually weighing those, and service providers striving to convince their customers that they're the best. So when we have that, I think we can have affordable health care in America where there aren't that many people who need subsidies, and the people who do are easy to subsidize because the health care is cheap and there aren't that many who need it. And then we don't have to have these horrible, ruthless debates in Washington about who is stuck with a ginormous bill. We can have a reasonable discussion about how to cover the very few people who are actually indigent. So that's what I've got to say for now, and I'd love to hear your questions.
Very good. Let's give a big hand to Kyle Varner. Kyle.
Thank you.
Well, I hope you've got a lot of questions for Kyle. I'm going to let him take a swig of water and rest for a moment and introduce you to the rest of the team. Would like you to meet Joe Kent, our Vice President for Research at the Grassroot Institute, who also directs our Maui programs. Joe, just step up a little bit and let everybody see you. Joe has been responsible for, about a couple dozen pieces in Maui News and other organs here on the island of Maui. How many of you have read his work? It's pretty good. Good stuff. Deals with housing, homelessness, hospitals, and so forth. We have a new member of the team, Sean Mitsui, who's joining us in communication and member relations. Sean, say hi. There you go. Good. So, and Sean is based on Oahu with me. And for those of you who don't know me, I'm Keli'i Akina. I'm your trustee at large in the Office of Hawaiian Affairs, thanks to many of you. But in addition to that, my love, of course, is the Grassroot Institute, which, as Kyle was talking about, is an organization that promotes the idea of competition so that consumers can actually have choice. I'd like to thank one of our sponsors who's here tonight, sponsoring this evening's program, from Peter Martin, over right here in the middle. Thanks. So, you've got questions for Kyle? While you put that together, I just want to say one more thing. Peggy Grand worked for Ronald Reagan for about a decade as his executive assistant. She heard and saw things that nobody else heard and saw. Now she's at liberty to share those things, and she's going to be here next week, August the 5th. A charming lady. She's written a wonderful book, and we'll do it a little more fancy. We'll have poo-poos and so forth. Here, August the 5th, 6 to 8:30 p.m., former executive assistant to President Ronald Reagan, Peggy Grand. You'll enjoy that very much. It's not a political function, by the way. She's here because she's got a lot of wisdom to share. Okay, questions for Kyle. Come on back over here.
How do you affect this sea change when this huge monstrosity and
Well, we affect this change one patient and one doctor at a time. We say, you're going to have this big system over here that's not working out for anyone, and we're going to opt out. And so, eventually I'm going to do this. I can't opt out right now because I'm a hospitalist, and there's just no way to practice my profession by opting out. But eventually, I'm going to do it. I'm going to say, I'm done, I'm opening my clinic, and there are no third parties allowed. And more people need to do that. And organizations like Liberty Health Share need to keep marketing themselves, keep demonstrating their value, and you're going to see more and more people opt out of the insurance system and go with Liberty Health Share. And little by little, we have to build a system and build a healthcare economy. And I think that's our only hope. We're not going to get Congress to solve this for us.
You mentioned Liberty Health Share as a cheap alternative. How were they, first of all, were they able to go do an end run around the Affordable Care Act to get those lower prices?
Yeah.
How do they do that?
An exemption was carved out from the Affordable Care Act when it was passed. These people existed prior to the Affordable Care Act. They were religious communities, primarily Mennonites, who didn't believe in insurance. And so they created these sharing ministries. They called it a health sharing ministry. And what that meant is that members of the church or people who are similarly minded were able to pool their resources, create a fund, and then help pay for medical expenses as they came up. So it's very similar to insurance, but it doesn't have underwriters per se, it's just the members. So the Affordable Care Act, when it was passed, had an exemption for these people. They said, we're not going to force these people into this system. So one of the organizations, which is Liberty Health Share, after the passage of the Affordable Care Act, saw an opportunity. They said, we're going to let more people in. We're going to let anybody in who wants to be in. You have to sign a vague statement saying, like, something to the effect of, I believe that healthcare is my personal responsibility, and I will take care of myself. It's a very vague description, and I mean they will accept atheists. They do say you have to live a, quote, godly life, but that means not going out and like getting into drunken bar fights, not using drugs, not smoking. Actually, stuff that is related to your health, and so they wanted to let as many people in as they could, and they're working very hard to spread the word, and they're growing by leaps and bounds.
Waiver, does it include other groups?
Yeah, it does. There are 3 other groups. To my knowledge, they are keeping themselves pretty much within their own religious organization. So for the other groups, I think you actually have to be a member of the church. But maybe, Phil?
There's my mom's, there's a Christian organization, just got to be sign your statement you're a Christian, you can join a Christian organization. Some are Liberty Share as well.
Yeah, so these are out there. I predict they're going to grow, and I predict eventually that they're going to become a threat to the insurance companies. And then the political fight is going to be saving them, and because the insurance companies will definitely go to Congress if they actually become a financial threat to the insurance industry. Pat?
Do you have any idea of what legislation it is that has prevented buying insurance across state lines? I've been trying to figure that out for years.
I think that it's actually individual states. So what happens is that every state has their own insurance commissioner and insurance regulations and requires reports and auditing. And what triggers that is that you have to be selling it in that state. So if I have an insurance company in Washington and I want to sell a plan in Hawaii, it would have to conform to the laws of Hawaii. And so the federal government can say, oh, no, that's interstate commerce. You states may not interfere with that. And so that's what I'm suggesting Congress should do, and that's what has been proposed that Congress should do, which is say, states, you may not interfere with interstate commerce in the sale of insurance. So Hawaii may not regulate a plan sold in Hawaii if it's originated in Washington. In Washington is where that would be regulated.
So where does that stand now? What is the status?
It's not been proposed yet. It was proposed in the presidential debate by President Trump. I hope someone at some point explained to him what he proposed. But that's as far as it's gotten to my knowledge. And everything that's being voted on today and in the next couple of weeks in the House and the Senate doesn't even address it. But call your congressman and tell them that's the one reform that can actually really help us.
Kyle, you left the state. Are there, and because of all the incentives too, are there other doctors that you found in the state that have a similar struggle, do you think, or are you just talking?
Yeah, I mean, I know a lot of docs in Oahu. And if you know Oahu, you know that the housing prices are insane. And so, well, just as an example, I lived in a one-bedroom, rather old, not updated recently, condominium when I lived in Oahu, and I paid like $2,800 a month for that. I mean, I can get a house with 5 bedrooms, a pool, a 3-car garage on the mainland for that. So that alone is putting a lot of people under stress. And I talked to some recruiters from Kaiser and Straub who said that they have a lot of docs who come for their interview. They get really excited about working in Hawaii, and then they go on a tour with a real estate agent, and they come back and they say, sorry, not doing it. So that's weighing on it, and the financial piece weighs on it too. So the reality is that you just can't make as much as a doctor in Hawaii as you do on the mainland. So you kind of have a double whammy. Your expenses go up, and your wages go down, and then you have a tax that's added onto it. So people often do end up making the financial decision. I mean, who wouldn't want to live in this beautiful state with such nice people? I mean, this is paradise, but paradise is too expensive in a lot of cases.
Regarding the cross-border insurance, who's against that? It's been talked about a long time. I just don't understand who is against it.
So I'm not aware of anybody publicly coming out and criticizing the idea, but somehow it never ends up making it into the bills that reach the floor. Somehow it just never ends up getting there. And what that tells me is that insurance company lobbyists are coming behind closed doors and saying, hey, take that out. And I mean, it's just an example of everything that's wrong with our current system.
You're saying it could be a single bill or something.
Yeah.
It seems like you couldn't get to every single senator. It seems like somebody, maybe just the state of Rand Hall or Don McCain or somebody propose it.
Yeah, it makes all the sense in the world. It crosses over from left to right. Everybody should support it. So it seems to me like that's a possibility, and that's why I mentioned it tonight, because that's the one thing that could actually get done. I don't think anything else is going to get done in Congress, but that could make things better.
I'm just curious. You just kind of briefly touched on malpractice, but defensive medicine and our tort reform and some of the other issues that certainly drive up the cost of our health care. And I don't know. Maybe you could tell us how much that drives up the cost of health care.
Yeah, well, I think it's a tremendous amount. So if I get sued, I have to, for the rest of my career, report that I have been sued every time I go to a different hospital, every time I change malpractice carriers, every time I apply for a new license or renew my license. I have to give an explanation, and I have to be judged by that person, institution, or licensing board about it. I've never been sued, luckily. Even if I'm found innocent, the hospital can settle, or the insurance company can settle without my consent because it's too expensive to defend me. So I don't want to get sued. I cross my T's, I dot my I's, I smile and try to make everyone happy. If you want an MRI, you get an MRI. If you want to be admitted to the hospital, you get admitted to the hospital. I don't tell people no unless it's for narcotics or something. And that's what most people do. We're terrified. And so I think you don't see it reflected in the numbers, but you see it reflected in our decision-making process, where more and more tests get ordered, more and more days in the hospital. I say, yeah, you could probably go home today, but why don't we just watch you one more day? And that one more day is a very low-yield day in terms of benefit to the patient. So,
has there been, or any initiatives, any bills to try to do something about work reform?
So Texas and Georgia have done a great job because what they have done is they've enacted what they call the gross negligence standard for care delivered under EMTALA. So let me define that. EMTALA is the Emergency Medical Treatment and Active Labor Act. It's the law that says you have to treat someone if they show up at the ER. You don't have any choice. They could have come the day before and shot someone in your hospital. You still have to treat them in your ER. So it's true. But care delivered under EMTALA in Texas and Georgia is protected, and you can only be sued if you commit gross negligence rather than simple negligence. And what gross negligence is defined as is less care than a careless person would demonstrate. So this deters lawsuits. And people feel much safer practicing emergency medicine and hospital medicine in the states of Texas and Georgia. And I think it can be reflected in for example, days people spend in the hospital and the number of unnecessary tests. So I'd advocate that nationwide, that for care delivered under EMTALA, care that I don't have a choice whether I provide you or not, we would adopt the gross negligence standard. There are other potential reforms, such as having some kind of a system to punish lawyers for bringing frivolous lawsuits. That pretty much doesn't exist right now. Some kind of binding arbitration or allowing binding arbitration would be another option.
Well, you just woke me up with punishing lawyers. That sounds like a great... But this has been fascinating. Any one last question for Kyle? Yes.
You say you're not concerned at all with condemnation, but I fear we're heading to a single-payer system, Medicare went way up. What can you say about that?
We are. So we're not going to have any changes to the healthcare system, I think, given the makeup of Congress right now and the kind of polarization in fighting. We're not going to have any significant changes. Yes, there's a huge movement out there to move towards a single-payer system. And so I likewise fear that that's what's going to happen, and I will fight it. But you can't fight single-payer healthcare system by saying, what we have now is great, or what we have now is a free market. No, what we have now is really, really horrible. The single-payer healthcare system would just make it worse. So we have to provide a positive alternative. And I say our positive alternative is third-party free, get rid of regulations that drive up the prices, get rid of cronyism, and let's have a system that's affordable, high quality, and accessible.
How do we do this? I mean, is it grassroots, one doctor, one patient?
It's one doctor and one patient at a time, and it's spreading the word little by little in events like this. It's going to be a long fight. But eventually, the healthcare system is going to reach kind of an inflection point where there's a financial crisis. And so the real key is to have all these ideas out there percolating, on the shelf ready. When the system reaches that crisis and that breaking point, we can pull them off the shelf, we can be ready to advocate that, and then maybe we can...
You're saying it's just going to implode.
It is, yeah. I mean, it's increasing at 2 to 3 times the rate of inflation. Within 50 years, I think that means that it would take the entire economy. At some point, something's got to give.
Let's give Kyle a big hand. Thank you very much, Kyle. Good job. Dr. Kyle Varner, and you can review or share with your friends tonight's presentation. It'll be put on the Grassroot Institute website.